If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. In today's episode, we're going to review the draft NICE guideline on type 2 diabetes, focusing on the visual summary created by NICE. I will cover the information over several episodes, so stay tuned. Right, let's jump into it. As you may know, the draft NICE guideline on type 2 diabetes is open for public consultation until October, and the final guidance is due in February 2026. It has attracted a lot of attention, but we need to remember that for now, it is only a draft, which means it could change. So we should not making any clinical decisions based on it yet. Today's episode is based on the NICE visual summary, and the link to it is in the episode description. The visual summary includes general guidance for all patients and specific guidance for 7 different groups of patients. In today's episode, we will review the general guidance and we will cover the various groups in future episodes. The first page of the draft visual summary sets out the general approach for all. NICE begins by emphasizing that diet and lifestyle are the foundation of management, and these need to be reinforced at every stage of the treatment pathway, pointing out that medicines should come on top of and not instead of these lifestyle measures. When choosing drug therapy, the draft recommends discussing the benefits and risks of every option. That includes looking at each drug's effectiveness for glycemic control, but also, and this is new compared with the previous guideline, weighing its impact on cardiovascular and renal outcomes. The guideline also stresses that if a person has more than one comorbidity, for example, obesity, cardiovascular disease, and chronic kidney disease, we should make a shared decision with the patient about which comorbidity to prioritize in terms of treatment. This means that we move away from a purely HbA1c driven model towards a model focused on complications and their prevention. On reviewing medicines, the draft says that before changing therapy, we should first optimize the current regimen, bearing in mind that it may be appropriate to continue some treatment options like, for example, SGLT2 inhibitors or GLP-1 receptor agonists, even if the effect on glycemic control is not perfect. In fact, the draft advises continuing SGLT2 inhibitors for their heart and kidney benefits, even if they're not achieving glucose or weight targets. For GLP-1 receptor agonists, the draft changes the stop rules. We will stop if they do not help the person achieve glycemic or weight goals, but only, and this is important, if the person does not have cardiovascular disease or early onset type 2 diabetes, understood as type 2 diabetes diagnosed under the age of 40. This is a huge change. Previously, stopping criteria were more tightly linked to weight and HbA1c thresholds. For example, if the person had not lost at least 3% of body weight and dropped the HbA1c by 1% within 6 months. Now, because of the cardiovascular benefits of GLP-1 receptor agonists, it basically means that for people with atherosclerotic cardiovascular disease, it is continued long-term regardless of weight loss or HbA1c change. And a similar, more relaxed attitude also applies to people with early onset type 2 diabetes. By why this recommendation? Well, this comes from trial evidence over the past decade. SGLT2 inhibitors have consistently reduced hospitalization for heart failure and slowed CKD progression, even when HbA1c effects were modest. Similarly, GLP-1 receptor agonists have reduced rates of major adverse cardiovascular events. Why these benefits? The pathophysiology is important here. SGLT2 inhibitors reduce intraglomerular pressure, improve renal hemodynamics, induce diuresis, and reduce preload and afterload on the heart. On the other hand, GLP-1 receptor agonists improve weight and have an effect on blood pressure and lipids. All these effects are the reason for the beneficial outcomes over and above glucose control. What this means in practice is that the decision to start or continue medicines is now less about HbA1c in isolation and more about long-term organ protection. SGLT2 inhibitors should be maintained even if glycemic targets aren't achieved. GLP-1 receptor agonists should be stopped if they don't achieve targets unless the person has early onset type 2 diabetes or established cardiovascular disease, in which case the longer-term benefits justify continuation. Finally, NICE advises against combining GLP-1 receptor agonists with DPP-4 inhibitors, as this combination offers no additional benefit. Why is this? Let's remember that DPP-4 inhibitors prevent breakdown of endogenous GLP-1, whereas GLP-1 receptor agonists directly activate GLP-1 receptors. Because the GLP-1 receptor agonists already saturate the receptors and are not affected by DPP-4 degradation, adding a DPP-4 inhibitor offers no additional glycemic or weight benefit. That's why guidelines recommend using one or the other, but never both. And before we end, let's also quickly list the main current recommendations in the draft guideline, making reference to the recommendations that have been either deleted or changed in a major way. First, the recommendation to start metformin alone as first line for most people without complications is gone. Now we will start dual therapy with metformin and an SGLT2 inhibitor as initial therapy, the reason being the need to maximize the cardiorenal benefits of SGLT2 inhibitors. Second, the restrictive conditions to starting GLP-1 receptor agonists have also gone. Now there's earlier and more explicit use of GLP-1 receptor agonists, specifically semaglutide, in order to maximize the weight and cardiovascular benefits of GLP-1 receptor agonists. In particular, semaglutide is the preferred option because it has the most consistent and strong evidence, as well as being the most cost-effective. Third, there's more weight and stratification by kidney function and frailty. As a result, the draft puts more weight on eGFR thresholds when deciding which medicines to use. And it also identifies frailty as a modifier, given that frailty increases treatment risks, such as dehydration, side effects, hypoglycemia, etc. Continuation criteria and stop rules for GLP-1 receptor agonists are now different, meaning that if a person has cardiovascular disease or early onset type 2 diabetes, the recommendation is to continue GLP-1 even if glycemic or weight targets are not fully met. The advice on how to introduce multiple medicines when initial therapy is combination therapy is also clearer. The draft specifies that medicines should be introduced one at a time. For example, first confirm tolerability of metformin, then of the SGLT2 inhibitor, then, if adding a GLP-1 receptor agonist, confirm tolerability of that in turn. Another change is that the draft is more explicit about reviewing medicines, checking effectiveness and discontinuing medicines that are not effective unless there is an additional benefit like cardiovascular or renal protection. Then, insulin guidance has also had a major refresh. The new draft simplifies the advice into a more practical, class-based approach, giving more flexibility as to whether human or analog insulins are recommended. This is a pragmatic response to insulin product withdrawals and shortages. By focusing on broader insulin classes instead of individual types, the guidance is more flexible and easier to apply even when supply issues arise. Another significant change is that GLP-1 receptor agonists can now be combined with insulin without the need for specialist supervision, making access easier and quicker in primary care. The ordering and priority of subsequent therapy options has also changed. The draft places DPP-4 inhibitors as the recommended option after initial treatment. Sulfonylureas, pioglitazone, and insulin remain options but are considered after DPP-4 inhibitors. The recommendation against combining GLP-1 receptor agonists with a DPP-4 inhibitor is repeated and is more strongly worded in the draft. The combination does not add benefits, so it should be avoided and removed if present. The priority of additional therapies is also more dependent on the clinical group that the patient belongs to. This means that the draft makes the escalation pathway group-specific and more prescriptive, with risks explicitly considered for each clinical category. And to summarize and close, let's review again how we think about treatment escalation from a general perspective. The general pathway looks like this. We will start most people on metformin plus an SGLT2 inhibitor right from the beginning. For people with atherosclerotic cardiovascular disease, obesity and early onset type 2 diabetes, we will consider semaglutide early in the pathway, not as a late rescue option. If HbA1c isn't controlled with first-line treatment and more glucose lowering is needed, the first recommended add-on is a DPP4 inhibitor because these are well tolerated, weight neutral, and easy to use. But this only applies as long as the patient is not on a GLP-1 receptor agonist. If a DPP4 inhibitor is not suitable or not effective, then other options like sulfonylureas, pioglitazone, or insulin can be introduced depending on the person's needs. And finally, frailty will modify how we manage treatment escalation, prioritizing safety and symptoms over artificial targets. The main message here is to remember that the rationale of the draft guideline is to avoid the old problem of incremental reactive prescribing, that is, waiting for one drug to fail before adding another, often leaving patients years without treatment that could protect their heart and kidneys. So that is it, an initial review of the new draft NICE guideline on type 2 diabetes, focusing on the visual summary. In the next episode, we will cover the recommendations for specific clinical groups. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.